One of the common discussions I have with students is they never know where they are. They find the data horribly complex, and there are some people that seem to look at a question and know the answer, and they look at the question and they just simply don't know what's going on. Well, good for the people who can just do it naturally, but that's not most of us. Most of us have to organize our material. You always have to have a disciplined approach to learning it. The point is, actually, medicine isn't hard, it's just really long. If you organize well, then you can take it into bite-sized pieces and practice it and develop it and not have this impossible challenge of memorizing first aid. We've talked about the easiest way to keep things in your mind is to have a picture with a story in it. Well, lots of times that is fine, but not the right answer. Today I want to talk about two other ways of organizing. I want to talk about the algorithm and I want to talk about tables. Now, that might seem self-evident to you, but I can tell you from my teaching, it isn't. And if this quick video helps you, great. If you already knew it, it's not going to take you long to look at it. Before we get into it, if you haven't already, subscribe. Every week, I post a new video to help you think like a doctor. I'm Dr. Philip Tisdall. I practiced for decades, and I've been teaching for well over a decade now in addition. My goal here is to bridge all of that data that you read and see on videos and let you organize it in a way that's going to help you in patient care, which is the best way to get ready for your exams. In previous videos, we've talked about the power of having a mental image of a process that you tell a story through. Today, we're going to talk about two other ways of doing it. One is going to be the algorithm, and the other is the use of a table. Before we discuss the particulars of algorithms and tables, let's just stop and consider this thought. Every system actually requires its own unique approach. So don't think you can take one and it's going to work for everything. That's kind of why you need a teacher in medicine. You've got to take each system and say, how do the people that practice in that system organize it? And use that rather than try to do something that you've contrived, like sketchy or other techniques, that you're just going to make it fit. In fact, medicine has very natural ways of making things fit because they work in patient care. So pictures and stories always works for pathophys, but there are other tools for different systems, and that's what we're going to go into more detail now. Let's start with an algorithm because that is always the preferred way in clinical medicine. So first, let's talk about what an algorithm is. In the simplest sense, an algorithm is just a series of steps that tell you how to do something. Believe it or not, a recipe is a perfect example of an algorithm. Take 2 cups of flour, add a cup of milk and 2 eggs, beat, stir, blah, blah, blah. All those series of steps is an algorithm. That's not what we're talking about here. We're talking about a specific type of algorithm, which is a decision tree. A decision tree is a series of if-then steps. And so the easiest way to understand that is, let's just use the single greatest example I use to teach. It's how we teach anemias. Boy, this is the only way to do it. Trust me, from someone that was in practice for 40 years and has taught for a decade, this one you're just going to live and breathe every day. It starts with this idea, first of all, of saying, do you have a place to start? And believe it or not, that's not as easy as it sounds. Because, when I say hematology and you say red blood cells, platelets, white cells, this is red blood cells. So you got to start with, they go up, they go down. So we're really starting with anemia. I mean, it sounds obvious to say, start from a clear place, anemia, which it turns out isn't clear. So make sure when you say, what's the definition of anemia? We go read about it. It's not our purpose to go into it, but things that you think are easy kind of aren't actually. So understand, start from a good place, anemia. Then what we're going to say is, where do I go next? That's the power of algorithms. It's not just that they organize for you, they tell you what to do next. It's just so helpful in medicine. And the way we do it is, it has to be a practical, useful step, meaning it has to be done in practice. One of the biggest troubles I see using algorithms is they are technically true and impractical. So, for example, the commonest way you'll see anemias divided is to increase loss, decrease production. Perfectly sensible, makes great sense physiologically. The problem is we do that with a reticulocyte count, which is a special test, and you ordered and you don't get the result till the next day. Well, that's not very helpful when you have 30 CBCs a day and patients in hospital and you have to solve your problem. You're not going to go to a step that takes you a whole day to get the result. So a very powerful and practical way is to go to red cell size. Isn't that great? Every CBC you're ever going to get is going to give you a red cell size. The mean cell volume in femtoliters is a precise, powerful, and really useful tool. They're small, they're normal, they're big. That works. But it turns out if you pay attention, and all good algorithms, testing teaches pathophys. It's not enough to just say small, medium, big. I mean, that works well because we think in those terms. But actually, the reason they're small is because you can't make hemoglobin. Well, now all of a sudden I've taken what looked to be a memorized and I've made it pathophysiologic, haven't I? Hemoglobin, heme, globin. So heme, I'll bet that's my sideroblastics. Globin's my thalassemias, and there's my iron sitting right in the middle of my globin, and that's going to be my iron deficiency and anemia chronic disease. So you can see exactly what I did, right? I took a nice little memorizing fact, turned it into pathophys, and created a picture with a story. If you can remember small is not making hemoglobin, hemoglobin, got it, I can do that. When we get to the larges, these are all defects in the ability to make DNA. So one of my favorite questions, everyone can do vitamin B12 folate. So that's great. It's true, works great. What always surprises people is one of the questions I love to ask is, I could always tell when it was chemotherapy day in the hospital, all the MCVs rose because everyone was on methotrexate, which is a folate blocker, and they all kind of had functional folate deficiency. So once you have this idea that large is DNA, you're set to go. So just think about how powerful this is. I've taken your anemias and I've taken it into perfectly pathophysiologic bite-sized pieces with one concept, small, normal, big. A great algorithm does that. And we can follow down the algorithm. Trust me, you want to go to the book, you want to get that algorithm, and you're going to know that. Let's just take an aside for a second here. We love your comments. We read them all. We take them really seriously. A couple of videos from now, we're going to take them on and address them all because it's so much fun. But one of the comments that I take to heart is that a number of you have pointed out, well, I get that you're doing algorithms and stories. It looks like I'm still memorizing. I went, that's true. I mean, it's not like I'm saying you don't have to repeat it a lot and learn it by heart. So what am I really saying? And I realized for my generation, memorizing meant rote memorizing. Rote memorizing means brutally taking a list out of all context and just beating it into your head. Like, who are the presidents of the United States? Got it. That is rote memorizing. But you notice, I'm not asking you to do that, am I? I'm not saying you don't have to commit things to memory, but all the things that you're committing to memory are in the context of understanding pathophys and patient care. So to learn them is to learn medicine. But I take your point to heart. This isn't effort-free, and you do have to repeat it a lot, but it's not just a blind list. It's not rote memorizing. So thanks for the comments. I take it to heart. When I say memorizing, I mean rote memorizing. Let's come back to one more comment on algorithms. The great danger of algorithms is if you get the first step wrong. Because if you've got an if-then and you go down the wrong side, trust me, you're never finding your way back to land. And a really good example of that, which I teach and always enjoy teaching because I point it out and then everyone, of course, forgets, is I point out a really powerful way of thinking about liver is to just use jaundice. And now all of a sudden, when I say liver, you think, jaundice is a good way of organizing this system, and it breaks into the two fundamental cells. It's either the hepatocyte or it's the biliary tree. And of course, there's Latin words for that. This is medicine. So processes are either hepatic or cholestatic. Once you divide liver into, is it one of those two, everything becomes easy. But look at the algorithm. There's a little step before that that says, is this unconjugated hyperbilirubinemia? Man, you missed that first step. You're never getting back to it. You just have to build the discipline to say, when it's over 80% unconjugated, it's either Gilbert's disease or hemolysis. So first rule of algorithms, don't miss the first step. You'll never find your way back to land. Some other lessons about algorithms. Remember that they're going to tell you what's next. Again, you don't try to put everything into them. We all love algorithms. You'll fall in love with them. You'll make your own. We all do it. And then you'll get this big hammer and you'll try to make everything fit. Got it. And then your whole algorithm finally seems so burdensome, you can't even use it anymore. Remember that when you're trying to organize something, it's 80-20. 20% of all your pathology is 80% of all of your patients. That's what you carry in your head. Don't carry the rare things. Just don't. It just becomes so burdensome that you might as well not even start in the first place. Go to Sketchy and memorize, your dragon. You just do the 80%. The other rule of algorithms is don't do things that are perfectly obvious. So one of the common criticisms I get from my anemia is, hey, where's acute hemorrhage? And my response is, hey, pretty sure you know if there's a pool of blood on the ground. So that's not going to be part of a differential because you're never going to walk into someone who's anemic and said, wow, you just vomited a lot of blood. I wonder why you're anemic. You don't need to solve that problem. So don't make it too burdensome. Don't include rare things unless don't miss this because they're critically important. Don't include things that are perfectly self-evident. Another good example of things that should be just taken out or your algorithms becomes impossible. For example, when you do diarrhea, always early, first step, is there a history of travel? Sure, there's a history of travel. Everything's possible. No history of travel. Lists about this big. Again, still with diarrhea. Are they on antibiotics? Well, that's a yes or no. You peel them off the beginning and all of a sudden your algorithm becomes really practical. So those are my rules of algorithm. They are the best thing in medicine. We all love them. If you can do something algorithmically, absolutely always do that. But remember, they're a tool for organizing and thinking. They're not going to solve every problem and world hunger. You're just going to use them a way of organizing things. Don't miss anemia and liver, by the way. They're killers. Okay, let's go on to tables. And you notice the happiness has gone from my face. The smile is drooping. I hate tables. Tables are just brutal. And sometimes you just can't friggin' avoid them. So you just sort of sigh, make sure your cup of coffee is full, tighten your belt and say, okay, here we go. It's a table. Here's the problem with tables. Most people look at them passively, which means the only table that's any use is the person who made it up. So what you want is a table from a teacher, not someone who's just feeling pretty smart about how they organize things. And let's take some examples. That's always the easiest way to do this. I think the table for congenital heart disease is actually really pretty good. That's a good example of a table that works. It's really hard. It's painful. I hate it. I got it. But still, it's really good. When you say congenital heart diseases, the first problem is, remember, you're only doing 80% of your patients. We're not doing rare things. Well, in congenital heart, 5 entities are 80% of all the diseases, right? So there's VSD, ASD, and we can go down the list. To understand those 5, you only need 3 pictures. Yeah, you don't just start with your table. First, what do I got to know to organize this? I got my 5 entities. I got my 3 pictures. And then you go, great, how do I organize this? Bad news, it's a table. Okay, just suck it up. Here it is. And what you're going to say is across the top, 5, you can do the 5. You got to, it's 80%. And then across the top, you say, what's the pathology? Now watch, it's clinical. What does my patient present with? Oh, physical exam. Yeah, but what are you going to hear? And then the last is, what happens? So here's a good example of where it really helps you organize. Let's just do Tetralogy of Fallot, right? Everyone can do the boot. Everyone can do, it's when the pulmonary thing is too narrow and they get their things. Everyone can do that. But here's a couple that students consistently don't do because they haven't had the discipline of adding it into the table. When you say, how does it present? It is the commonest cause, wait for it, think how testable this is. It's the commonest cause of congenital cyanosis. Well, there's no examiner in the world didn't see that little plum ready to be picked. And if you haven't had the discipline of adding it into your table, well, it's a harder question. Here's the other really choice pearl that comes out of it. You say, I've got it. I've diagnosed my tetralogy. What do I do next? Yeah, 25 to 30% of them are 22q11ds syndrome. Yeah, that's the commonest of the deletion syndrome. You think we don't all have that? Oh, you mean because that's going to be all the other diseases like hypoparathyroidism and low lymphocytes? You don't think that isn't testable? So if you kind of forget that tetralogy is part of your 2211QS, it just is a lot harder. A table forces you to say, what happens in natural history? I've got Tetralogy of Fallot. Did you put it in the context of 22q11ds? So it hurts. I get it. I don't like them any better than you, but sometimes they're just flat out really powerful. You just bite the bullet and do the work. We're all grinders. And anytime you're feeling anxious and you want to deal with your anxiety, go practice your tables. It really makes you feel like you're doing something. Okay, so no doubt charming hearing me talk about the pleasures and pains of algorithms and tables. So here's the reverse responsibility. Don't watch me draw them. I'm merely showing you how you learn to draw them. I don't think I truly had that anemia in my head till I'd done it 10 or 20 times. And then I would forget it every 3 months. I carry it around with me and I have to remind myself. Sure, 50 years later I can do it. So let me tell you, you know how you do a table? You get the table, you do the left side and the right side, and you leave the middle blank. Yeah, you have to fill it in. So, back when I was giving lectures live, I would give blank pieces of paper with the table cells empty. So yes, you have to write it out. You have to write that algorithm, and it hurts and it takes practice and you forget it immediately because our brains are terrible. You have to have it as a way of thinking, and you can only do that if you carry it in your head, and our brains require repetition. If you can't draw it, you don't know it. That's true for algorithms and tables. Don't want to hear the complaining. If this video has helped you, be sure to tune in next week, because we're going to talk to one of my truly good professional colleagues, and we're going to get her to talk about what it was like when she had to go from being a many, many year wonderful teacher to becoming a medical educator along the lines of this. So she can come and tell you it's true whether you're a student or you're a professor. Come and listen to her talk about what it was like when she entered this world. And as a lead into this video, make sure you watch last week's video, which was on presentation, pathophysiology, and natural history. We'll see you next time.